This patient, the 22-year-old male, the student, comes from Palamu district, Jharkhand. Comes with the chief complaint of progressive right lower abdominal swelling for last 4 months. Coming to the detailed history of the present illness, patient was apparently asymptomatic 4 months back when he noticed a swelling over the right lower abdomen. It was initially painless to start with, but for the last 1 month, he is complaining of a dull aching pain over that side with a sensation of heaviness. The pain does not interfere with daily movements. Constant dull aching pain with dragging sensation with no radiation, not associated with nausea, vomiting, change in bowel habit, flatulence. Pain is exaggerated with physical activity and diminished by taking rest and analgesics. Patient gives history of increased frequency of micturition without any burning sensation. No history of blood mixed stool, alteration of bowel habit, tenesmus, colic abdominal pain, or prolonged diarrhea. There is no history of hematuria, burning micturition, loin to groin pain, swelling does not reduce in size after passing of urine. There is no history of contact with TB patient, prolonged cough, evening rise of temperature, non-healing ulcer over mouth or anus. No history of recent or past acute pain over the right iliac or periumbilical. No history of fever with chill, rigor, or night sweat. No history of any painful leg swelling. No history of any other lump in abdomen. No history of neck, axillary, or groin swelling. No history of cough, hemoptysis, chest pain, dyspnea. No history of headache, seizure episode, projectile vomiting, loss of consciousness. No history of anorexia, generalized weakness, and recent weight loss. No history of breast enlargement. Coming to the past history, patient has been born with right undescended testis, for which no medical opinion or intervention was done. And other secondary sexual characters were normal. No significant past medical or surgical history. No history of blood transfusion or any other known comorbidities like hypertension, diabetes, asthma, or any other thing. There is no history of ATT intake or any contact with TB patient in family, and no known food or drug allergy. Coming to the family history, there is no history of similar complaints in family or any other cancer-related death in family. Patient has two other siblings, one brother, younger brother, and one sister. Personal history, patient takes mixed vegetarian, non-vegetarian diet. The sleep is normal. Bowel habit is regular. Bladder habit, the patient has, per history, there is a recent increase in frequency of urine, but without any burning sensation. There is no history of any addiction of smoking, marijuana, or any other alcohol. Patient is unmarried and has no high risk behavior. Coming to the summary from the history that we got, it's a 22-year unmarried male student with no comorbidity and history of right undescended testis. Complaints of progressive right lower abdomen swelling since last 4 months with recent onset dull aching and dragging pain, not associated with fever, weight loss, vomiting, anorexia, or alteration of bowel habit, but with increased urinary frequency. So should I continue with the examination part?
What do you think is the cause of pain here?
So the swelling is there for last 4 months, but the pain has developed recently.
Yeah.
It
So
could
what
be
could be the cause of the pain?
as the swelling is increasing, it could be irritating. The size of the swelling is increasing. It could be irritating the local peritoneum, the parietal peritoneum. That could be cause of the localized pain, as there is no radiation or
So
any
when
other
you are giving me a diagnosis, you keep in mind that it's a swelling with pain. Okay.
So the pain is very minimal. The dull aching is not causing any. It's
Hey, Mainak,
more of a.
Mainak,
Yes, sir. Yes, sir.
you have a summary in front of you.
Yes, sir. Yes, sir. Yes,
It's
sir.
not a
With
painless
recent onset
progressive
dull
swelling.
aching and dragging pain. Yes, sir.
Yes. So it's a pain with swelling in the
Yes, sir.
region.
Yes, sir.
Okay. So when you are
Yes, sir.
making a differential diagnosis, you should consider both the
Yes,
factors.
yes, yes, sir. Yes, sir.
Okay.
So coming to the clinical examination, the general examination, patient is conscious, cooperative, well-oriented with time, place, person, after bright, with the physical status ECOG score 0. The BMI is 24.5 per square meter, and the body surface area is 1.75 per square meter. Pulse is 84 beats per minute, regular, rhythmic, and normovolumic. BP is 112 by 70 millimeter. Mercury in the left arm in supine position. There is no pallor, no edema, cyanosis, icterus, and clubbing. The left supraclavicular lymph node is not enlarged. There is no palpable axillary or inguinal erythema. No evidence of gynecomastia. There is male pattern body hair distribution can be seen. On spinal examination, there is no gibbous or any tender point. Coming to the local examination, the examination procedure was explained and proper consent was taken. Exposure was done from neck to mid-thigh with inspection from three directions in natural light. Abdomen was normal, scaphoid in shape with normal body hair distribution. Umbilicus was central and inverted. All quadrants were moving proportionately with respiration. There was no visible or prominent veins or any pulsation or peristalsis. The hernial orifice were intact. There was no bulge seen on cuff. Right scrotal skin was ill-developed with undescended testis. Ill-defined bulge was noted over the right iliac fossa and over the left manubrium sternum. Inspection from above, and this is the picture. Inspection from right lateral. Inspection was done at the level of the abdomen. This is the right-sided undescended testis that could be seen.
What about the left testis? What about the left testis?
Left testis was on inspection. The left testis was normal. Looks normal, but now I will correlate my findings, inspectory findings, with palpation. So palpation was done after proper consent, and patient was asked to void the bladder before doing any palpatory examination. Inspectory findings were confirmed. There was no rise in temperature in any of the region of the abdomen. On palpation, 8 by 6 centimeter mass occupying the right iliac fossa, extending up to the right lumbar area, umbilical and hypogastric region was found. It was not crossing midline. The mass was non-tender, hard in consistency. The surface was smooth, well-defined margin. There was no intrinsic mobility, and it was not moving with respiration. Fingers can be insinuated all around the mass. It becomes less prominent on doing the muscle contraction by leg rising or by carnates, and the mass was non-ballotable. The mass does not become prominent or changes position on knee, elbow, or left lateral position. The renal angle fullness, was not demonstrated. There was no renal angle fullness or tenderness. No other organomegaly was found on deep palpation. Testis was absent in the right scrotal sac. No palpable swelling in the inguinal canal, and no expansile calf impulse over the hernial sites. The left testis was normal in shape, size, consistency, and sensation. There was a 3 by 2 centimeter swelling over the left manubrium, which was painless, bony hard, with smooth surface, well-defined margin, and overlying skin free. This finding was not elicited during history, but it was an incidental finding, and the patient was unaware of this. Percussion, the liver dullness was found up to fifth right intercostal space, and the span was measured in mid-clavicular line. It was 12 centimeter. There was no free fluid, and shifting dullness was absent. Percussion over the lump was dull, and it was separated from the liver dullness by a band of resonance. Rest of the abdomen was resonant on percussion. Bowel sounds were normal. No buoy or venous hum was heard over the mass. On digital rectal examination, there were no piles, fissure, or fistula. The anal tone was normal. Stool was there. A pelvic mass was palpable in the right rectovesical pouch, which was hard in consistency and non-tender. Other system examination like respiratory, cardiovascular, and central nervous system did not elicit any other findings. So after examination, the case summary comes like it was a 22-year unmarried male student with no comorbidity and history of right undescended testis, complaining of progressive right lower abdominal swelling since last 4 months, with recent onset dull aching and dragging pain, not associated with fever, weight loss, vomiting, anorexia, or alteration of bowel habit, but with increased urinary frequency. On examination, the swelling is 8 by 6 centimeters, smooth, hard, right iliolumbar in location, with no guarding, non-tender, retroperitoneal, non-mobile, non-ballotable, margin well-defined, finger insinuable all around. Another incidental 2 by 3 centimeter bony non-tender swelling was detected over the left manubrium sternum, which was recently diagnosed. So, based on my history and clinical examination, my provisional diagnosis is a right-sided primary testicular mass of undescended testis with a suspected bony metastasis.
Do you have a differential diagnosis?
Yes, sir.
He doesn't have a diagnosis, Tarun. So where is the question of differential?
Yeah.
He's saying testicular
Right.
mass.
Yeah.
Testicular
Right.
mass is no diagnosis.
Sir, I should alter my provisional diagnosis, sir. So it is a right-sided primary testicular germ cell tumor of undescended testis with suspected bony metastasis.
Why do you say germ cell now?
Sir, more than 90% of testicular mass are germ cell tumors.
But 10% are not. So
10%,
how do you know? How do you know this patient is in 90% or 10%? What is
Sir,
there in your history and clinical examination to suggest that it is a germ cell tumor?
Sir, for the non-germ cell tumor, like the Leydig cell tumor and Sertoli cell tumors, there should be some clinical symptoms and signs that should suggest it. Like for Leydig cell tumor, patients should have had history of increased testosterone-induced changes, whereas in Sertoli cell tumors, patient should have increased female hormone-related secondary sexual characters like gynecomastia and body hair distribution. So from history, since the patient is having normal,
Do you see testosterone secreting tumors, leading tumors, or functional tumors? Is it the same age group as this patient?
no, sir, functional tumors are seen in on a more higher age group. In the second decade, this tumors are mostly on the germ cell tumors. Second decade, mostly it is
So,
non-seminomatous germ cell tumor are more common in the second decade.
so testosterone secreting tumors can be seen at a very young age also, where it leads to precautious
Yes, sir.
puberty.
Yes, sir.
Whereas Sertoli cells are seen in Sertoli cells are seen in relatively higher age groups.
Yes, sir.
So what else there is that in your history would suggest this is a germ cell tumor?
You are giving a pathological diagnosis. My knock has disappeared.
So this is like you are saying this cecal mass or lymphoma. You are saying it's a differential diagnosis that
No,
I.
I'm talking of germ cell tumor.
So my provisional diagnosis was a testicular mass, sir. It appears like a testicular mass, undescended testicular mass, which I need to for further evaluation based
Manak,
on.
Manak, that is also not a diagnosis. Because in the next line, you go back to the slide. The next line, you are writing the axial bone metastasis.
Yes, sir. Yes, sir.
So it cannot be a testicular mass as a diagnosis cannot be accepted.
Sir, on rare occasions, sir, in 3% of cases, bony metastasis, primary bony metastasis can be found, sir. It's a rare finding, but
What is the difference between a testicular mass, testicular tumor, and a testicular cancer?
testicular mass can be benign, inflammatory, or neoplastic, sir.
So that,
Among the neoplastic mass, it could be germ cell and non-germ cell tumor. Along with it could be other rare malignancies that can also be found in testes. But the most common, more than 90%, it is the germ cell tumor. So based on the clinical examination and history, I cannot confirm that whether it is a mass, it is a benign lesion or it's a malignant lesion.
and what is this metastasis stands for? Which of the benign lesions of the testis metastasize?
That's a mistake from myself. I should not have told that's a metastasis. It's a suspected. It's a completely separate bony lesion that needs further evaluation.
So you mean to say that they are disconnected?
Based on clinical examination and history, I cannot confirm the uh, exact
So,
origin of that bony
when
mass.
you are going to make a clinical diagnosis, are you going to
Yes,
connect the two or you're not going to connect the two?
sir. Since
So
both the
this means do you have a single working provisional diagnosis or do you have two working provisional diagnosis?
sir, at present I am having a single working diagnosis, but
So what is that working diagnosis that you have?
sir, my working diagnosis it's a primary testicular germ cell tumor or malignancy with suspected bony metastasis.
Okay. So this germ cell tumor histological diagnosis that you making in this test is, do you
Yes,
make
sir.
it for other cancers also? Do you
But,
say squamous cell cancer of the oral cavity, infiltrating ductal carcinoma of the breast, clear cell carcinoma of the kidney? Do
no,
you?
sir, we don't. No, sir, no.
So why here?
Based on the age, the distribution,
Huh.
And and according to the distribution of tumor profile, like
But that is
more than that.
but then 80% of the breast tumors are infiltrating ductal carcinoma.
Yes, sir. Yes, sir.
है ना? So still you say it is a case of carcinoma of the left breast.
Yes, sir. We don't
You
say
don't
that
call it a ductal carcinoma of the breast.
until and unless we have histological proof, we cannot confirm the diagnosis.
So what should be the diagnosis?
That it will be testicular neoplasm. Sir.
It will be a malignant testicular
Testicular
neoplasm when you are
neoplasm.
getting a metastasis.
Yes, sir.
If you are going to take that much of a time in making a provisional diagnosis, it's going to be a disaster in the exam. Now, where is the pain?
So the pain is a dragging sensation which the patient is complaining over the mass, but on palpation there is no tenderness over the. So
Okay. So, do you get the dragging sensation in the testicular masses or in the undescended testis with the that lies in the iliac fossa?
no, sir.
Where do you get the dragging sensation?
The dragging sensation or the dull pain, normally in a small undetected mass or non-palpable mass, it is not there, sir. When some mass uh, suddenly grows in size, patient
What
can have
what do
this.
you what do you mean by word dragging? What
Patient gives a
kind of
history of.
what kind of masses give rise to dragging pain?
Patient was giving a sense of fullness and a heaviness, sir.
See, now you're saying something else. When you're presenting, you are saying something else. So that mean you mean to say that what you're presenting in the history and examination is wrong? Your history of pain was not proper?
So I think the some summary of the history that I am saying, the dragging pain, I without
You are
knowing the
also
exact
saying
meaning.
it is dull aching.
Yes, sir. Dull aching pain. Yes, sir.
Yeah. So dull aching and dragging. You
Yes,
have
sir.
used two terminologies.
Yes, sir.
So when does the iliac fossa mass present with dull aching pain or a dragging pain? You have to understand that loss of pain sensation is the
Hmm.
characteristic of testicular masses,
Yes, sir.
malignant testicular masses.
Yes, sir. Yes, sir. Yes, sir.
Dragging pain or dragging sensation is because of the weight of the testis,
Yes, sir.
which pulls the spermatic cord. This is intra-abdominal testis.
Yes, sir.
So what is being dragged and why there is a dull aching pain?
Sir, because of the weight of the mass which has grown rapidly,
Hmm.
the patient is having a dull aching pain, which is a very characteristically it is dull, and there is a continuous aching pain on that thing. But it is not hampering his daily mobility or any other activity. But a constant sense of heaviness is there over the right iliac fossa.
See, sense of heaviness and dull aching is entirely different thing. That is why I had specifically asked when you summarized your history
Yes, sir.
that you are saying that the pain is dull aching.
Yes, sir.
And what organ produces dull aching pain? And what exactly is dull aching pain? And what is the other histories you have to take when you say that the pain is dull aching, which were missing in your history?
I had asked whether there was any acute episode of pain in the periumbilical or right iliac fossa in that same duration or in the past. For my differential diagnosis of appendicular lump, if the patient gives a history of any appendicitis which has converted into a lump, patient can also present with pain, but for that patient will have a history of acute episode of pain with fever, vomiting. That was absent for this patient. In my differential, sir, I have kept some benign and some malignant pathologies. For malignant, it could be cecal mass based on the location, but patient does not give any history of any, like patient doesn't have anemia or pallor or any history of blood mixed stool or any colicky abdominal pain or any alteration of bowel habit. For that reason, I have excluded any luminal pathology in the large bowel. appendicular lump, it could be a differential diagnosis, but the patient doesn't give any history of acute episode of appendicitis. Uh, Another diagnosis could be ileocecal TB, hyperplastic variety, but patient doesn't give any history of any past history of tuberculosis or ATT or contact with any positive tuberculosis patient.
Stop for a minute.
Yes, sir.
What is there in your history and examination? These are supporting these differential diagnoses. What finding in your examination and history is
Yes, sir.
supporting these 5 differential diagnoses?
Sir, the consistency and the location of the mass, sir. Location of the mass and the consistency with retroperitoneal origin is supporting either a retroperitoneal sarcoma or a lymphoma, and as well as appendicular lump which has densely adhered with the local surrounding structure. And for cecal mass, generally they are could be mobile, but if it is adhered with the surrounding structure, it can also become immobile. Based on the location of the right iliac fossa, sir, it should be a more broad aspect. It should be a colonic mass. I should be speaking, not a cecal mass specifically.
No, what do you mean
Because,
by mass as a differential diagnosis?
sir, mass could be inflammatory or it could be neoplastic, sir. A patient can have inflammatory changes where there could be hypertrophy in the wall, as seen in inflammatory bowel disease,
So
or the patient.
what is there in your history to suggest that, or in your
Sir,
exam?
no, sir. These are I have taken history, and they have all come as negative history, sir. There is no history of any prolonged alteration of bowel habit or any diarrhea or any bloody history of bloody stool.
So basically, there is nothing in your history to suggest a differential. Is there?
That
So why do you need to keep a differential? See, if I had been presenting this case, I would not keep a
yes,
differential. I have a patient with cryptorchidism. I get a intra-abdominal lump.
yes, sir.
I got a bony metastasis. Why should I keep a differential?
I need further clinical. I need further evaluation to exclude any ectopic testis or testis in the inguinal canal. I am not sure whether the testis is completely undescended or testis was there in the right iliac fossa. Since the patient gives history of undescended testis, that has come as my primary diagnosis. But until and unless I do further evaluation, I cannot confirm that it's primarily it is because of that the mass is or the tumor is from the testis. So I need to keep all my differential handies that which are more common in the right iliac fossa.
So that means when you are going to go for the biochemistry, you are going to
Yes, sir.
do all the tumor markers like CEA to rule out a cecal cancer. You are going to do a biopsy and send it for tuberculosis, gene expert testing.
I will first do a imaging study, sir, to confirm.
Imaging is going to show you a mass, nothing else. Going to see your workup. I should be seeing workup for all your differentials, isn't it?
Sir, first I would like to exclude my provisional diagnosis. If my provisional diagnosis is a testicular mass, so I will do investigation based on that.
Beta,
If
you
it
don't
is,
exclude a diagnosis, you make a diagnosis.
yeah, I will first to confirm my diagnosis. So if my diagnosis is
So
not
how are you
confirmed,
going to confirm your diagnosis if you are dealing with 5 different differentials, which are entirely different from your primary diagnosis? They are nowhere related to it also. Trying to understand what I'm saying.
yes, sir.
If you have done an imaging and found something else, you could have think in terms of a differential at that particular time. There is nothing in your history and examination to suggest these differentials. So because there is nothing in your history and examination to support any differential diagnosis, why keep them? Your provisional diagnosis and your differential diagnosis depends upon what you have presented.
Yes, sir.
And if there is nothing to support a differential, then you say that in my history and examination, there is nothing to support a differential diagnosis. I don't have a differential diagnosis at this point of time. I have it after imaging or after biochemistry, that's entirely different. But at this particular point of time, this is a clear-cut case. You have a cryptorchidism, you have a right iliac fossa mass, retroperitoneal. In nature, you have a dragging pain, and you have a suspected bone metastasis. You understand?
Yes, sir, I got it, sir.
So, like when you say ileocecal tuberculosis, Crohn's disease, how do you explain your metastasis from a ileocecal tuberculosis or a Crohn's
In
disease?
that case, sir, it would be a second second pathology, sir.
But where is it? Where is it written your differential that there is a second pathology with it?
No, sir.
When you are writing ileocecal tuberculosis, you have not written with.
Yes, sir. I got it, sir. I got the point, sir.
So you understand. So
Yes, sir. I got the point.
so when you are making a differential, if a differential fits into your history and clinical examination, fine.
Yes, sir.
Last time also in the breast case, same thing was told to you. Don't keep
Yes, sir.
differentials just for counting, for
Yes, sir.
numbers. If it does not fit in your history and examination, don't keep it.
Sir, so based on my provisional diagnosis, I would like to confirm my diagnosis. So I would do first I will do an ultrasonography as an extension of my clinical examination. Ultrasound was done for abdomen, inguinal region as well as transscrotal with a high frequency probe. The inguinal canal was found to be empty. There was no ectopic testis. The left testis was normal in size, shape, and texture. No mass, no microcalcification was found. There was a heterogeneous hypoequic mass 8 by 6 centimeter found in the right pelvic region with internal vascularity and adherent to urinary bladder on the right side. Uh, there was a 3 into 1 centimeter infraumbilical retroperitoneal lymph node that was also detected in the ultrasound. Right-sided hydronephrosis and hydroureter was present up to the mass lesion. No ascites, no hepatosplenomegaly, and no bowel wall thickening was observed. These are the pictures of the ultrasound.
To your ultrasound, it is a intra-abdominal swelling.
Sir, these pictures are of intra-abdominal ultrasound. Yes, sir.
Your examination showed it to be retroperitoneal mass.
And along with it, sir, there was right-sided hydronephrosis, and as well as there was a retroperitoneal lymph node in the infraumbilical region, sir. Was
Okay.
this initial diagnosis was found from based on ultrasound.
So what is your diagnosis now?
Sir, after that I did some routine blood investigation as well as to confirm my diagnosis. I also performed the tumor markers that are related with testicular germ cell tumors. Routine examination was found to be normal, but the tumor markers that were done were found to be raised. Sir. LDH was 356 unit per liter, where the normal range was up to 248. The upper limit was up to 248. The alpha fetoprotein was up to 840 nanogram per ml, and beta ECG was up to 2146 milli equivalent milli international unit per ml. Sir. Sir, after that, based on my ultrasound finding, since there was positive retroperitoneal lymph node, it was decided to do a total CECT thorax abdomen pelvis for this patient for better delineation and understanding of the lesion, as well as to rule out any distant pulmonary metastasis. I would like to share
I thought,
the
Mainak, you had found a bone metastasis, so why did you go for a CECT thorax abdomen pelvis?
based on my
Based on your clinical diagnosis where you're suspecting a bone metastasis,
yes, sir.
is it ideal thing to go for?
As the alpha fetoprotein in my blood investigation tumor marker, the alpha fetoprotein was raised, sir, as well as beta HCG. Since the alpha fetoprotein was raised, the chance of it being a seminoma is less. This testicular germ cell tumor is more likely to be a non-seminomatous germ cell tumor. And sir, based on the new NCCN guidelines, based on guidelines, sir, PET CT scan is not indicated, or any bone scan or PET CT scan is not
Even if
indicated.
even if there is a metastatic disease in even in M1?
Even in M1A or M1B disease, PET CT is not indicated. Upfront PET CT is not indicated uh, for diagnosing or staging of germ cell tumors, non-seminomatous germ cell tumor. So I said PET CT was not done for this patient. CECT thorax abdomen pelvis was done.
With the bone scan.
Sir, bone scan was not done, sir.
Why?
Sir, bone scan and PET
If you
CT
are
both
not
are.
doing, then how are you going to pick up other bone lesions?
Sir, it is not going to change the staging, sir. If there is a single bone mets or multiple bone mets, the staging is not going to change.
So in non-seminomatous germ cell tumor, it is the staging workup that you are important, or you need to know what are the lesions and how are you going to monitor the treatment and RECIST criteria? If you don't know how many target lesions are there, what are you going to do at the end of BEP?
Based on the guidelines, sir, they are not saying to get a PET CT or a bone scan to be done and to get a follow-up PET CT or bone scan for the evaluation of non-germ cell breast, non-germ cell testicular tumors, sir. So if we consider NCCN guideline as well as the ESMO guideline,
Or
there is
do they
no role
say
of PET CT.
do they say that if you're suspecting a bone metastasis, don't do a bone scan, don't do a PET scan?
Sir, it is written bone scan and PET CT is not indicated even in M1B or non-visceral metastasis or bony metastasis of germ cell tumors.
Patient who has a bony metastasis, if you are not going to look up at how many number of bones are involved and where else the bony metastasis is, how are you going to evaluate the uh,
So
treatment
PET CT is only indicated, sir, in a proven seminomatous germ cell tumor, sir. And also even after, and that also after neoadjuvant chemotherapy with more than 3 centimeter retroperitoneal mass remaining.
Beta, you are talking of a different situation. I am talking of a M1 disease.
Yes, sir. For M1A and M1B disease, they are also, sir, based on the ESMO and NCCN guideline for non-seminomatous germ cell tumor, PET CT is not indicated. I would like to share the CT scan, sir.
That you have shown already. You are gone beyond that.
No, sir. I would like to show the video of the scan, sir, where the
Okay.
lesions and all the things can be.
Okay.
Sir, this is the CECT thorax, abdomen, pelvis. As we go down over the manubrium in the left side, here we can observe there is a bony lesion. It's a well-defined bony lesion can be observed in the left side of manubrium. So and the CT scan doesn't show any definite lung nodule or mediastinal mass or any lymph nodes.
Are you
So
supposed to comment? Are you supposed to comment on lung nodules in this window?
no, sir. I need a lung window. I need a lung window for to comment on lung nodules, sir. But
So when you're showing a chest, when you're showing this window, then why are you commenting on lymph nodules? You should not comment on anything which is
yes,
not seen in that particular image.
yes, sir. I don't have the lung window with me, so that's why I was commenting here only. But obviously, I cannot comment on any lung nodule or mediastinal node in this window. I need a lung window for commenting on that. So coming to the abdomen, there is no liver nodule or hepatosplenomegaly. Right-sided hydronephrosis can be seen, and as we are moving down in the retroperitoneum, sir, here, sir, in the infrahilar region, para-aortic or aortocaval region, sir, there is a large 3 by 2 centimeter with central necrosis. A large node can be seen, sir, the entire aortocaval region. Further down, uh, now the retroperitoneal mass is visible with central necrosis can be seen and heterogeneous density, and is seen to be pushing the bladder, as well as the lateral wall of bladder appears to be infiltrated. Based on this CT, this could be explaining the history. From history, the patient is giving increased frequency. Uh, this could be a reason why the patient was complaining of increased urinary frequency.
The findings that you are showing,
Yes, sir.
that mass is not adhered to rectum, mass is adhered to urinary bladder. What is
Sir,
its significance now?
significance, sir, the CT is confirming that it is not a colonic origin, and
With the markers, you still want to confirm colonic origin?
no, sir, no, sir.
I'm
Like it
disappointed.
is,
I'm horribly disappointed.
sir. This is actually helping us to stage the end staging can be confirmed, sir. The end staging, the size of the tumor can be confirmed. The size of the nodal metastasis, the number of the retroperitoneal nodal metastasis, and
Based on your CT findings, what you just described, do you want to do any other investigation?
I would like to do a cystoscopy, sir, to rule out any
Right.
direct invasion, bladder invasion, sir. So, sir, the CCT thorax finding that was there, that it was a heterogeneous enhancing 9 by 8 by 7 centimeter mass with internal non-enhancing necrotic areas and calcifications in the right infraumbilical region with extension into right spermatic pod. Sir, this finding was reported, but I could not evaluate this finding that this tumor was having extension in right spermatic pod. But the CT was also elaborating on the extension with infiltration in the lateral wall of the urinary bladder. Superiorly, it was involving the right ureter. Anteriorly, it was abutting anterior abdominal wall. But there was but with the mass, there was no obvious bony bowel and vascular infiltration. There was along with a 3 by 2 centimeter well-defined soft tissue mass in right aortocaval region with luminal narrowing of IBC and ill-defined peripheral enhancing mass lesion with respect to manogram body towards the left side with bony permeation. Right testis was not visualized, and CECD thorax findings was the lung window was very normal. Sir, we did a USG guided biopsy from both the pelvic mass as well as the sternal mass. Sternal mass biopsy was done upfront. From the pelvic mass, it was USG guided, and in the both the lesion, it came out to be poorly differentiated neoplasm. So we sent for immunohistochemistry of that lesion, which had certain immunohistochemistry markers that confirm that it is a metastatic mixed germ cell tumor. Like PLAP, placental recurrent phosphatase positive, OCT34 was positive, SAL4, CD117 and CD30 were positive. Sir. So it was confirmed that it is a metastatic mixed germ cell lineage.
So how will you manage this case?
Sir, uh, uh, based on my CT and immunohistochemistry finding, my final diagnosis is it's a right-sided primary testicular non-seminomatous germ cell tumor of undescended testis with bone mets with staging of TX, N2, M1, M1B, SX.
Why TX?
Since we have not done an orchidectomy, and this is undescended testis, we cannot confirm the clinical staging, sorry, of the primary tumor, sir. And sir, it is SX because of the same reason the S score is done post orchidectomy, and in spite of high beta HCG and alpha fetoprotein, the S marker will be considered as X. And M1B because it is a visceral non-pulmonary metastasis was confirmed, and N2 because of the size dimension of the rectoperitoneal lymph node that was found in the CT scan. So, sir, this directly goes into stage 3C, and based on international germ cell cancer collaborative group prognostic group, it should be falling in the poor prognostic group, sir, because of non-pulmonary bony metastasis.
Do you know? Have you read the NCC this TNM classification AJCC?
Yes, sir. Yes, sir.
Did you read the note below the T staging? Is it written? What are the two exceptions to the surgery? What are the two places where you don't have to do an orchidectomy to T stage the tumor?
So TX clinically TX is the primary tumor cannot be assessed. So, sir, for this patient, we cannot assess the primary tumor, sir. We have just taken a biopsy that has proven its origin. So, for that reason, I have given TX as the diagnosis. Apart from that, we cannot also confirm whether, based on the biopsy, the lymphovascular invasion cannot be confirmed. So,
See, you go back to AJCC classification and read the whole chapter. It is very clearly written, except for PTIS and PT4. extent of primary tumor is classified by radical orchiectomy. This means these are the two
Yes, sir.
exceptions where radical orchiectomy is not required.
Yes, sir.
When you are getting a extra testicular spread,
You're saying that it's invading the bladder.
Yes, sir.
tumor is
Yes, sir.
invading the bladder,
Yes,
and
sir.
you are still calling it TX that you cannot assess the primary tumor. You are very much assessing the primary tumor because this is going to be your target lesion when you are one of the target lesion when you are going to do resist after
Yes, sir.
evaluation of response. You understand?
Sir, in the AJCC, the T4 is written as tumor which invades scrotum with or without vascular or lymphatic invasion, sir.
Fine, fine,
So, sir,
fine.
I cannot
You
say
say
that it is a T4 lesion, sir, based on the
why?
AJCC classification.
Why? Why? It is extra testicular extension or not? AJCC TNM is for testicular tumor which occurs in testis. But when you
Yes,
have
sir.
to apply this AJCC to cryptorchidism, what are you going to do?
Sir, in
Are
AJCC, they
you
have
not
not.
going to? So that means you can't stage it. Then you should not apply any of the thing for the extra testicular or cryptorchidism. Then even your N or M is not applicable because it is only for the tumors occurring in the testis, isn't it?
Yes, sir.
So
But, sir,
you are not going to extrapolate it to the cryptorchidism.
for the cryptorchidism part, there is no proper guideline that will provide in AJCC, sir.
Beta, you have not read the AJCC chapter completely. You have seen only the table. That is your problem.
Since there is a extra testicular spread, it should be a CT4N2 M1B SX, sir. But the final staging will be still be the same, sir.
Yeah, obviously, when it is a M1 disease, it's going to be the same.
In case of M1A disease, if it is SX, then it should be considered as a stage 3. But yes, sir, they have not subclassified it as A, B, or C.
Yes. So you are reading it now. You have not read it before. What are
Yes,
the
sir.
two components that are there in mixed germ cell tumors?
These are embryonal cell component, yolk sac component, and teratoma component, sir. Sir, since it is a stage 3C with IG prognostic group 4 prognosis, sir, we are going to give systemic chemotherapy for this patient upfront. We would like to give 4 cycle of BEP regimen. And then after that, we are after 6 weeks of the 4 cycle of completion of 4 cycle of chemotherapy, we are going to reevaluate uh, based on tumor markers and based
Is
on
your, is your intent of treatment curative or palliative in this case?
sir, for germ cell tumors, sir, the treatment is always curative, even if in presence of metastasis.
So do you want to do something else before straight away giving
Yes, sir.
chemotherapy?
Since the patient is unmarried, I would like to counsel the patient regarding sperm banking. Because following the chemotherapy regimen treatment, patient there is a 30% chance that patient might lose the fertility based on due to the chemotherapy, and also followed by the surgical intervention that we are going to do after that post chemotherapy if required. So, counseling for sperm banking should always be given for the patient to preserve the uh, for the future parenthood. Sir.
What do you mean by counseling to be given?
Patient should be counseled and the patient should be informed that the risk of the loss of there is a risk of loss of fertility post treatment, and so patient should be preserving his sperm and also should be checking the, we should be doing a sperm analysis to see whether adequate sperm count and sperm characters are there or not. So these things are compulsory to be done.
Okay, why did you choose BEP? What other regimens are available and when they are used?
Sir, I have chosen BEP since the patient is a non-smoker. Patient doesn't give any history of COPD, and no, there is no history. And on the RFT examination, the urea creatinine are found to be normal, so there is no renal parameter derangement or GFR derangement. So for that reason, I have chosen bleomycin along with etoposide and cisplatin, because platinum-based chemotherapy are category 1 chemotherapy regimen for for advanced stage germ cell tumors.
So it's a 3C disease. What did you do to rule out brain metastasis?
And since the beta HCG was not more than 5,000, and there was no clinical symptom that was suggesting correlating with suspicion of brain metastasis. So brain metastasis was not ruled out for this patient. There are some indications that are provided in the guideline where brain metastasis needs to be ruled out. Bone metastasis is not an indication where we have to routinely rule out the brain metastasis.
So what are the conditions where brain MRI has to be done?
Sir, in case of definite diagnosis of choriocarcinoma or beta HCG has more than 5,000 beta HCG value evaluation, or in spite uh, after chemotherapy, if there is progression of tumor markers, and along with patient is having symptom suggesting increased intracranial tension or recent onset epilepsy, loss of consciousness, projectile vomiting, we should be thinking of any. We should be thinking in the line of brain metastasis, and we should be going for a brain MRI for that patient. Yes, sir. Post orchidectomy AFP levels, as well as post chemotherapy tumor marker levels.
Yes, but post chemotherapy is post archaectomy, na?
Yes, sir. Yes, sir.
Except for 3C. So what do you do in 3C? That's the question. What you are doing is you are not reading the footnotes. Same thing you did in AJCC, the same thing you are doing in NCCN. You have to try to understand what the guidelines is saying.
So the clinical indication is with high suspicion of brain metastasis, sir, with features of
High
raised ICG,
suspicion of with the raised beta HCG.
with raised beta
Uh,
ICG
if
above
you
a
have
particular level.
extensive lung metastasis,
Yes, sir. Extensive lung
if
metastasis,
you
high
have
suspicion. Yes, sir.
if you have neurological symptoms or other non-visceral metastasis, those are the conditions where it should be done.
Yes, sir.
Uh, it should be done. So after giving the BEP, what are you going to do? How much BEP you are going to give?
Sir, we are going to give 4 cycle of BEP, sir,
Hmm.
for this patient. We
Hmm.
are going to give 100 milligram per meter square etoposide, 20 milligram per meter square cisplatin, and 30 units of bleomycin. We are going to give the maximum dose of bleomycin, maximum tolerable dose of bleomycin for this patient of 360
Why
milligram.
why why 4 cycles and not 3 cycles? When do you give 3 cycles and when do you give 4 cycles?
Sir, good, good prognosis based on IG/CCG, as well as for the stage 2 up to stage 2 disease, 3 cycle of BEP regimen
Yeah.
is indicated. But sir, for intermediate and poor prognosis and all stage 3 diseases, 4 cycle of BEP regimen is indicated.
What is toxic? What is toxic lifetime dose of bleomycin?
Sir, like sir,
Means how much?
360.
How many you can't go beyond this particular
Yes,
dose
sir. Up to sir 12 bleomycin 30 units dose can be given, sir. We
in
cannot go
units. In units.
in,
Tell
yes,
me in
sir.
units.
360 units, sir, total lifetime dose.
It's 400 units.
Okay, sir. 400. Generally, sir, 4 cycle four BEP regimen, total 12 bleomycin is given. More than 12 bleomycin is not given, sir.
What is the prerequisite for giving bleomycin?
Sir, the patient should be a non-smoker. Patient or should have left
That
smoking.
you mean to say a person who's smoking you can't give bleomycin to her?
Sir, for heavy smoker, according to NCCN guideline, heavy smoker bleomycin is better to avoid.
So how do you evaluate a patient? What do you look for
Sir,
in a
we should
patient?
be
You
doing pulmonary function test, DCLO study to look for alveolar exchange. and we should exclude the patient having any COPD or also we have to check for GFR to look for any renal function
Right.
problems.
It's DLCO you need for it. Diffusion capacity of carbon monoxide.
Yes, sir. DLCO is the more preferred investigation to check for bleomycin therapies.
What instructions will you give to your anesthetist
For
when patient has received bleomycin? Is it important to tell the anesthetist that patient has received bleomycin?
that patient has a high risk of having oxygen toxicity.
Hmm.
With chance of oxygen-related pulmonary fibrosis is high. So patient should be the anesthetist should be counseled that patient has taken bleomycin and FiO2 value should be kept low during intubation. Sir.
They should not get 100% oxygen,
Yes,
and post-operative also should avoid 100% oxygen.
yes, sir. Patient should not be kept in 100% oxygen during intra-op and post-op period.
Okay, then what you will do after giving
Sir, after completing the fourth cycle of bleomycin, patient should be evaluated 4 to 6 weeks after the last dose of chemotherapy. Patient should undergo repeat CECT thorax abdomen pelvis and with the tumor markers. If the tumor markers has, we will look for the fall of tumor markers, whether it has come normalized from the previous raised value, and we will also look for the primary lesion as well as the retroperitoneal lesions, and also the bony lesions that was there. Based on the response, we are going to plan the further therapy. If there is a complete response, patient there is if there is a complete response, in spite of complete response in stage 3C disease, it is preferred that patient should undergo nerve sparing retroperitoneal bilateral retroperitoneal lymphadenopathy.
if the markers have not normalized, then what will you do?
Sir, if the markers have not normalized or showing progression, sir, we should be planning for a second line chemotherapy for this patient. It means that the patient, this is not a cisplatin sensitive germ cell tumor, and we should be uh, shifting to a second line chemotherapy which does not have bleomycin in it. We can go for second line as VIP or TIP, sir. Second line chemotherapy, where the TIP contains taxanes with ifosfamide and cisplatin, or we can go for VIP, where we have we give etoposide with ifosfamide and cisplatin. Or there is a regimen we can go for VEIP, where we add vinblastine in case of paclitaxel. There is a study going on called the Tiger trial, phase 3, which are looking for high dose carboplatin in case of this advanced stage 3C testicular CA, where they are comparing this standard second line regimen of PIP with dose dense carboplatin. And this study is still ongoing. In those days, carboplatin, sir, there is a requirement of stem cell infusion, sir. If high dose of carboplatin is being used, then stem cell infusion is required because it causes significant bone marrow suppression.
Hello, good evening, sir. So please uh, explain regarding brain MRI indication in this case, sir. Not in this case, in the carcinoma testis case, like in stage 2 or 3, not very clear.
Basically, it is recommended for patients who have a very high AFP levels. Typical recommendation is more than 5,000. Patient who has extensive pulmonary or non-visceral diseases, and a patient who has neurological
Yes, sir.
symptoms. But on the other hand, you should go for bone scan because you have a bone tumor. Even though
Yes, sir.
NCCN
Yes, sir.
guidelines does not recommend bone tumors, because the bone
Yes, sir.
metastasis from a non-germ cell tumor is rare. That is why you will
Yes,
not
sir.
find much on the bone metastasis in the guidelines.
Yes, sir.
So, but if you get a bone lesion, then it is important that you should try to find out that if it is the solitary bone lesion or there are multiple bone lesions. Because the intent of treatment in germ cell tumors is always curative.
Yes, sir.
And whenever you are going to treat a patient with a curative intent, you need to know all the lesions which are present before you start the treatment. And then at the end of the treatment, you have to know which are the lesions which you require to surgically excise or treat with a second line therapy. That is why it is important that you should know exactly how many lesions are present and where they are located. If a lesion
Thank
does
you.
not respond to chemotherapy, then you may have to plan a surgery to resect that lesion. But if you do
Yes, sir.
not know how many lesions are present in the body, how are you going to go around uh, deciding whether your response is complete or incomplete, or if there is a residual disease present in the any of the sites? There are a lot of situations which are not dealt by the NCCN guidelines or many other guidelines. And one of them is a presence of bone metastasis, then presence of cryptorchidism or a testicular tumor in a cryptorchidism. If you go through the NCCN guidelines does not talk about testicular tumor developing in cryptorchidism.
Yes,
Cryptorchidism. Yes.
yes, sir. Yes,
So actually you cannot apply, even TNM classification does not talk about cryptorchidism.
yes, sir.
So there are a lot of gray areas when you are dealing with the guidelines, because the guidelines are for common situations. Guidelines are not made for extraordinary situations. For the extraordinary situation, you have to take extraordinary measures.
Good questions. Should we
Yeah.
get when we when we diagnose a patient of uh, uh, testicular cryptorchidism with bony mets, should we go for a PET scan in this case? Should
PET
we undergo
actually,
PET scan?
PET actually is not recommended for non-germ cell tumor.
Yes,
The
sir. Yes, sir.
reason for non-recommendation is that the sensitivity or specificity of a PET is almost similar to that of a CT scan.
Yes, sir.
Mhm.
So because the sensitivity and specificity is not higher than the CT scan,
Mm.
so they say that you don't get an advantage over the PET scan. So that is they are not talking about evaluation of bone at all here. Most of the time, the metastasis from a non-germ cell tumor is visceral metastasis.
Yes, sir.
But what is happening here is that in this particular case, it's a non. So when you have a non-visceral metastasis, you have to think differently that how are you going to evaluate the skeletal system.
Yes.
So even though the uptake FDG uptake may not increase the sensitivity and specificity of the diagnostic non-seminomatous GST, but then
Mm.
uh, a bone scan perhaps is going to pick up and let you know if there are other lesions also. Then once you have a three mixed germ cell tumor, three component tumor, then
Mm.
ideally you should take a bone biopsy also. Try to
Yes,
find
sir.
out that which component is there in the bony lesion. It is not for it is usually it can be one component or two component, and the third component may not be there in that bone metastasis. So these are special situations which require special things to be done. And there is a lot. The guidelines are basically for garden variety. Take into account the special situations. So when you try to apply a guideline onto a special situation, you end up with a problem. Like in NCCN, the first thing they do is a archaeectomy, determine the histology. Once they determine the histology, then they decide which investigation algorithm is to be picked up. And you have not done a archaeectomy. Then they say that you should not do a biopsy through the skin.
Mm.
Here you have done an ultrasound guided biopsy through the skin. So that is again contradictory to the guidelines. So there are a lot of situations where you have to go in contradiction with the guidelines, or the guidelines may not explain every situation to you.
Yes, sir.
So this is something which is important to understand, that the guidelines are applied to garden variety. Guidelines cannot be applied to special circumstances. So Mainak, what are the genetic factors that you should look for in a testicular tumor?
Sir, testicular tumor has
Germ cell
no
tumor in
definite
specific.
germ cell. Yes, sir. Specific germ cell tumors. They don't have any very specific genetic or hereditary pattern of distribution. Sir, some studies has shown that uh, inversion of 12p is a karyotypic marker that can show that it could be a germ cell tumor. If we go for karyotyping, where the immunohistochemistry is also not able to differentiate between the origin of the tumor. And sir, it has been found that in Klinefelter syndromes or in gonadal dysgenesis syndromes, the relative risk of having testicular tumor is more because of testicular atrophy and high FSH values. As per study done by Wade et al. In 2002, uh, they found that study was done. Sorry, it was by Oliver in 2011 in MRC trial, where they studied in stage 1 seminoma. Their finding was there the pre-treatment FSH, high pre-treatment FSH has increased risk of having contralateral testicular malignancy. Like if one testis is having germ cell tumor, the chance of having testicular malignancy in other testis also increases. But that was based on high FSH value, and it was
I think you should go back and read. There are 6 specific loci and markers that you should be looking for in a germ cell tumor.
sir. I remember one marker, sir. It was in X chromosome long arm 27, where the gene is TGCT1 gene, which has a high up to 10 times high susceptibility for testicular.
There are 6 specific genetic locus or genetic events that can happen in germ cell tumors. Beside that, there are number of somatic mutations which are found in germ cell tumors. The commonest is the P53 as usual,
Yes,
and
sir.
then P10, and then there are a lot of others.
In metastatic chemo-resistant recurrence, to also look for high tumor burden as well as look for MSIH, MMR, TMMR markers.
They are just the markers which are used for selecting therapies. And there are reasons for the cancer carcinogenesis to occur.
Yes, sir. Like P53 is the most common.
Uh, there are syndromes also associated with lot of things. And what are the third line chemotherapies?
Yes, sir. The third line is patient has after salvage chemotherapy or after salvage surgery, or patient has recurred. Uh, that means patient second line chemotherapy has also failed. Like dose dense chemotherapy has also failed, and patient has either recurred or the tumor markers is increasing. So there are studies that are showing in where we have exhausted etoposide and we have exhausted the maximum dose of bleomycin, then we can go shift to other chemotherapy regimen, among which the most common is gemcitabine oxaliplatin, or we can give gemcitabine paclitaxel. They are considered as the last line of chemotherapy that can be given as a third line chemotherapy regimen.
And what do you give for high tumor burden and MSI unstable?
Sir, if high tumor burden and MSI unstable disease is found, pembrolizumab has been found to be effective, but the number of study is very less. There is not no high level of evidence is not there. A few studies are there which are showing the duration of stable disease is increased with respect to placebo. But the disease progress, the duration of stable disease is there, but it has not shown any change in overall survival.
Sir, I have one small doubt,
Yeah,
sir.
Keshav.
Sir, in a scenario where a patient is having a testicular mass with a raised alpha fetoprotein and beta HCG, and post orchidectomy if it comes pure seminoma, and tumor markers post orchidectomy tumor markers level if it comes completely normal. So should we consider that as a seminoma, or since the pre-orchidectomy there was a raised alpha fetoprotein and beta HCG, should we consider as a non-seminoma germ cell tumor, sir?
It's a non-seminoma. AFP is only and only raised with non-seminomatous germ cell tumors.
Like sir, post orchidectomy if it comes normal, so
Then
can we
also, even if we are, that's the reason for doing a pre-orchidectomy markers.
okay, sir.
Because in staging you consider post-orchidectomy markers. So then
Yes,
why are you doing pre-orchidectomy markers? One of the reasons is this, the question you asked.
okay, sir.
If
So in this
AFP was ever raised, yeah, if AFP is ever raised, that means the tumor is non-seminomatous to begin with.
so in this case, sir, undescended testis is usually a seminomatous tumor. Most common
I
one
know,
is
I know. This
seminomatous.
is a little atypical case. Most common tumor in undescended testis is seminoma. But
Yes,
if
sir.
if AFP is raised, then I think we have to consider it as non-seminoma. Intratubular germ cell neoplasia.
The intertubular germ cell neoplasia is the in situ malignancy, sir.
So where do you find it and how do you treat it?
Sir, it is considered that in case of a proven germ cell tumor, the other testis there is a 5% chance of having harboring intertubular germ cell tumor. So it is diagnosed based on ultrasound with any abnormal mass-like lesion or any finding microcalcifications in the other testis, and biopsy is the only
So
way
how,
how
right, biopsy is the only way to.
to diagnose intertubercular germ cell tumor.
So once if you have diagnosed, then how do you treat it? What do you do?
Sir, if it is a small localized lesion, we can go for partial orchidectomy.
Okay.
And sir, the options are we can go for partial orchidectomy for that patient if we have removed the primary, or if
So there is no standard treatment. You can either go for low dose radiation, partial orchidectomy, or follow the patient up with serial ultrasound.
yes, sir, we can go for intensive surveillance also.
So this is one thing which you missed out in this patient. You are supposed to. There are two high risk factors in this patient, the one you presented for
Yes, sir.
intratubular germ cell neoplasm in the left testes. One is the cryptoid testis and second is the tumor of the testes.
Yes, sir.
So you should ideally screen the other testes for any intratubular germ cell neoplasm,
Sir,
even in follow-up after treatment.
yes, sir. Yes. Sir, the high resolution ultrasound, transtotal ultrasound was done for this patient, but no abnormality was detected.
Did
So,
did you do a
the,
Doppler?
yes, sir, Doppler study was also done.
So you didn't tell us the Doppler findings.
Sir, for the testicular mass, the Doppler was done along with ultrasound. Sir, the testicular for the testicular mass, the Doppler findings was there was vascularity in the undescended testicular.
Contralateral test. Contralateral
No,
testis.
sir, I have not mentioned about the Doppler finding of contralateral.
Missed it.
Yes, sir, I have missed it.
Contralateral testis is not important, isn't it?
No, sir, it is very important for this patient. They have a high chance of harboring malignancy in the contralateral testis. If the testis has normal Scheib size consistency and sensation, and with no abnormality or microlithiasis, we can avoid a Doppler study. Sir. If there is an abnormality in abnormal lesion that was detected with microcalcification, we should be going for a Doppler analysis for that microlithiasis rich lesion. Sir.
What is the long-term effect of etoposide?
So etoposide has uh, myelogenous secondary malignancy. It can lead to myeloid leukemias as well as myelodysplasia or aplasia.
What is the toxic dose, total dose, for after which the chances of
Sir, more than 2
uh,
grams. More than 2 gram.